Next joining us will be Dr. Andrew Satlin, Chief Medical Officer at Transposon Therapeutics. Dr. Satlin will tell us about a phase 2A study of TPN 101, a nucleoside reverse transcriptase inhibitor in people with C9orf72 related ALS and FTD.
Great.
Welcome.
Yeah, Fernando, thanks very much. Thanks to ALS ONE for inviting us to give this talk. So Transposon Therapeutics is developing a drug called TPN 101 in a variety of neurologic diseases, including C9orf72 related ALS and FTD. That slide's not advancing for some reason. Try again.
On our side, it's not in presenter view yet.
Okay. Is that?
It now,
yeah.
Yep. Thank you.
Okay, great. Thank you. Sorry about that.
No worries.
So I think, as everyone is aware, mislocalization of TDP-43 from the nucleus to the cytoplasm is one of the hallmarks of most cases, of course, of ALS. One function of TDP-43 in the nucleus is to aid in suppressing the activity of retrotransposable elements, including one called line 1. So TDP-43 loss of function is associated with overexpression of line 1, which is the only functionally competent retrotransposable element in the human genome. And then once line 1 is transcribed, it goes through a life cycle that's very much like that of retroviruses. So this is not an endogenous retrovirus. It's a retrotransposable element that's similar to those, but it goes through a life cycle like them. And the reverse transcription of line 1 RNA back to complementary DNA leads to activation of the innate immune system, which in a variety of models results in neuroinflammation and neurodegeneration. And a reverse transcriptase inhibitor can block this process and suppress the TDP-43 related toxicity in preclinical models. So Transposon's TPN 101 is a potent inhibitor of the line 1 reverse transcriptase. It's actually a repurposed drug that went through phase 2 in HIV. It's equally effective against the HIV reverse transcriptase as the line 1 reverse transcriptase, and none of the other available or studied HIV reverse transcriptase inhibitors has nearly the potency of TPN 101 for the line 1 reverse transcriptase. So TPN 101 does not directly address the C9orf72 gene or pathology, but patients with C9 ALS are an enriched population for detecting the biomarker and clinical changes that are due to inhibition of line 1. And there's several reasons for that. First, the C9 mutation is associated with increased line 1 expression, which may be due to gain of function effects of both the C9 hexanucleotide repeat RNA as well as the dipeptide repeat proteins. C9 haploinsufficiency or loss of function is associated with an increased innate immune activation and inflammatory markers. This is because C9 has some role in tamping down the cGAS-STING inflammatory pathway. And then, of course, in a general sense, we wanted to study a population in a small and relatively short study. And C9, there's some evidence for having a faster rate of progression than non-genetic forms of ALS, so that would give us a better opportunity to do that. So we conducted a 42-patient phase 2 trial of TPN 101 in patients with a C9 mutation and a clinical diagnosis of either ALS or FTD. And this presentation is just going to focus on the ALS results. We randomized 24 patients with ALS, 3-2, to either TPN 101 400 milligrams or placebo for 24 weeks of double-blind treatment, and then all patients who completed that period received open-label treatment for an additional 24 weeks. We measured biomarkers of neurodegeneration and neuroinflammation as they relate, of course, to our mechanism. And then we did standard clinical assessments as well, the ALS FRSR and slow vital capacity, which I'll describe. And we did the CDR sum of boxes and the FTD population. So just briefly, this is a drug that's very well tolerated. We only had 2 dropouts, drug discontinuations in the TPN 101 group, which was 15 patients, and none in the placebo group. There were a couple of patients who we did not get LPs on at the 24-week point in the study, and several more who we were unable, unfortunately, to get LPs on in the open label at the end of the open label period. So that will be reflected in the data that I'll show you. But generally, we have good biomarker and clinical data in the vast majority of patients who are in this trial. So after 24 weeks of double-blind treatment, patients in the TPN 101 group had lower levels of NFL and NFH than patients in the placebo group. The levels for these 2 analytes remained low with continued TPN 101 treatment during the open label period. As I've mentioned, dropouts and lumbar puncture refusals resulted in data being available only from 2 patients in the original placebo group at week 48. So that, of course, limits the interpretation of those data. We don't focus on them, but they're indicated here in the red dotted line. And you can see the ends at the bottom. We started out with 15 and 9 and ended up for most of these analytes with 12 and 7 at the 24-week time point. UCHL1 and tau were also lower in the TPN 101 group than in the placebo group at week 24. There were apparent numerical increases in these markers at week 48. That's unexplained, but they may reflect variations. As you can see, these are still relatively small sample sizes, and these may reflect variation due to that fact. Given the consistent effects, though, that we saw across these neurodegeneration biomarkers in the CSF, we did a global statistical test combining these 4, NFL, NFH, tau, and UCHL1. And the consistency of the effect on neurodegeneration is confirmed by a statistically significant difference between the drug group and the placebo group at week 24 with a p-value less than 0.01 for drug compared to placebo. So again, this is a relatively small trial, but we're seeing consistent effects on various markers of neurodegeneration. They're known to be elevated in patients with ALS, and the global statistical test confirms that. We also looked at a variety of markers of neuroinflammation. So for this mechanism, an ideal measure of target engagement, of course, would be levels of the complementary single-strand line 1 DNA that's produced by the reverse transcriptase. Unfortunately, after a long effort, we have not been able to develop a reliable assay to measure that. But downstream of that, given that this activates through cGAS sting, that that DNA triggers activation of the innate immune system through cGAS sting mechanism, and one of the earliest cytokines that's affected by that is IL-6. So we consider IL-6 to be most proximate to our mechanism of action. And what we see here is that TPN 101 was also associated with reductions in IL-6, as well as in the markers neopterin and osteopontin. And in here as well, these levels remained low during the additional 24 weeks of open label treatment. and again, with the same caveat, unfortunately, with regard to the original placebo group. And as with the neurodegeneration markers, the consistency of the effect on neuroinflammation is demonstrated by a trend on the global statistical test where we combined IL-6, neopterin, and osteopontin. This test had a p-value of 0.08. So again, a consistent effect as we would have predicted on the measures of neuroinflammation as well. I'll turn briefly as well to our clinical measures, the ALS-FRS and SVC. What we saw is that, on the ALS-FRS, both the TPM 101 group and the placebo group declined during the 24 weeks of double-blind treatment. And both of them declined at rates that were predicted for an untreated population compared to a variety of other natural history studies, as well as other clinical trials that have been done in this population. And that's represented by the shaded area. Actually, the shaded area we took directly from the recent phase 3 AMYLEX trial. However, with longer treatment in the open label period, the original TPN 101 group has stabilization of their ALS-FRS scores, whereas the placebo group that is only starting on treatment at week 24 continues to decline at the expected rate. So this signal of what we see as an emerging clinical effect is consistent with the onset of clinical benefit lagging behind biomarker effects, which is, of course, often seen in treatments for neurodegenerative disorders. Turning to the slow vital capacity measure, the percent decline in SVC in the double-blind period was 8.7% with TPN 101, compared with 17.5% in the placebo group, representing about a 50% reduction in the rate of decline during the double-blind period, in other words, over the first 24 weeks of treatment. After 48 weeks of treatment with TPN 101, the percent decline in slow vital capacity was 20%, compared with what would be expected of roughly 30% as seen in the Andrews meta-analysis of 3 large ALS databases, again here indicated by the shaded area. And here, where we're seeing an earlier effect on this clinical measure, with switching the placebo group to active treatment after 24 weeks, we do start to see an attenuation in that group as well on the rate of decline in SVC. So, summary. TPN 101 had excellent safety and tolerability, which supports its further development at the 400 milligram dose. It was associated with lowering of biomarkers of neurodegeneration and neuroinflammation, including NFL and IL-6. The global statistical tests that we've shown support the effects on neurodegeneration and neuroinflammation. We see that treatment with TPN 101 slowed disease progression on the ALS-FRS-R with longer treatment, and there was a reduction in the rate of decline in SVC in the first 24 weeks of treatment. Of course, this is a small exploratory study. We don't have statistical significance for most of these measures. 1 or 2 of the biomarker measures were statistically significant, but overall, what we're seeing is a consistent pattern of changes that we predicted we would see with this mechanism of action, and the emergence of signals, at least, of a clinical effect that give us confidence to move forward in larger trials. Thanks very much. Happy to take questions. I think we probably have time.
We do. Thank you, Andrew. Thanks for a great presentation. I guess I'll actually start off with a question that I have. So you showed us neuroinflammatory biomarkers, IL-6, neopterin, osteopontin. You explained to us the rationale for IL-6. I'm curious how you arrived at the neopterin and the osteopontin, and I wondered if you looked at anything else in the neuroinflammatory kind of a broader panel than those.
Yeah, so we were also interested in microglial activation because that's also, of course, downstream of activation of the innate immune system. And so that was our primary interest with those other markers. We did look at a number of other biomarkers, and we had inconsistent results on those or no effective drug. On other markers such as IL-8, IL-15, IL-10, TREM2, a variety of things. But nothing that was in the opposite direction. So we're either seeing inconsistent or no effects, or we're seeing these effects that appear to be consistent with our mechanism of action.
We have a couple of questions from the chat. So the first one relates to your development process, I think. So how much preclinical toxicity data did you need in order to design and dose a 24-week study like this?
Yeah, so this drug has already been through a full tox package. It's actually, the tox package is NDA ready because it was advanced through phase 2, through large phase 2B studies in HIV. So over 200 HIV patients were exposed to drug for long periods of time, up to 2 years, with a very good safety profile. There were a large number of, not a large, there were the requisite number of phase 1 studies that were done as well in that indication. And then prior to this, we had conducted a similar size trial in progressive supranuclear palsy at the same dose. Actually, there we used a range of doses, 100, 200, and 400, but 400 was the highest dose. And very consistent safety effects there as well. So we were fortunate in coming up with this mechanism and this hypothesis to test that there was a drug available that we could move immediately into phase 2.
And I think that speaks a little bit to one of the questions that was asked as well around the rationale for assessing only a single dose going forward. Could you explain why not try a broader dose range?
Yeah, so we did that in the PSP study, and we saw best effects actually there also on NFL and IL-6 at the 400 milligram dose. And given the size of this study and the fact that we also included patients with FTD, so that the ALS population was only 24 patients altogether, we didn't want to end up with too small groups by studying additional doses in this trial.
That does lead to another question I had, and thank you for your focus on ALS in this presentation, but can you speak to any effects that you're seeing in folks who are living with C9 FTD?
Yeah, first, the FTD population in the study was even smaller. It was only 18 patients. We did not see the same type of consistent biomarker effects in the FTD population as we did in the ALS population. Nor did we see anything striking on any of the clinical measures. Consistently, the CDR sum of boxes was a bit lower numerically in the treated group throughout actually the full 48 weeks compared to the placebo group. But it's very hard to make anything of that.
Do you think that teaches us anything about potentially the role of neuroinflammation in FTD versus ALS, or is it too premature?
Yeah, we don't know. It's a good question. It may be. I mean, there's the C9 mechanism is obviously involved in both, but we're not necessarily. Again, we use C9 as an enrichment strategy, and it did give us the opportunity to study the FTD population as well. But the major mechanism here is increased expression of line 1, which we believe is related to the de-repression as a result of dysfunction of TDP-43.
A couple other questions. One specific to this drug. What's the brain to plasma ratio of the molecule?
Yeah, so consistently, we've seen about 30% penetration, which results in exposures that's in CSF, of course, which results in exposures in the CSF that are many multiples of the actually of the EC90 for the line 1 reverse transcriptase.
Mhm. And one more question. Is there any blood NFL data available for this drug in this study?
We did. We looked at blood levels of all of the biomarkers as well, and similar to what some of the other presenters have shown, very variable results, nothing consistent there. Hard to know what to make of that, except of course, you're seeing a lot of variability because the levels are over an order of magnitude or 2 orders of magnitude lower than they are in the CSF. So detecting differences between drug and placebo may become more difficult for that reason. But no, we did look at all of those, but we did not see consistent effects in the blood markers.
Thank you so much. Thanks for a great presentation and answering the questions.